Chapter 19, drugs used for pain management, page 289 in your book. Pain is defined as an unpleasant sensation that is part of a larger situation that the patient is experiencing. Patient's pain is highly subjective, can be influenced by behavioral, physiological, sensory, emotional, and cultural factors. The way that a patient perceives pain is called nocioception, and this is, again, very subjective and can be different from patient to patient. Pain threshold is where the pain is first perceived by the patient, and pain tolerance is the person's ability to endure the pain. Pain is then divided into acute or chronic. Acute pain is less than 3 months. Chronic pain is greater than 3 months. Acute is generally from an injury. Chronic pain usually occurs with a slower onset and is not necessarily related to an acute injury and can be divided down further into malignant or non-malignant, meaning cancer or non-cancerous pain. Pain can be classified by its pathophysiology. So nocioceptive is a dull and aching pain. Somatic is pain that's arising from the musculoskeletal system or the skin. Visceral originates from the abdomen, the organs in the thoracic cavity. And neuropathic results from nerve injury. This can be described as stabbing and burning. And idiopathic is a nonspecific pain of unknown origin. So when you hear quotes such as, "These menstrual cramps are getting worse and worse," where would you think that this pain is arising from? So it's coming from the abdominal cavity, so we would call this a visceral pain. We would classify it as visceral. Patient states, "I had a virus a couple months ago, but now everything just hurts." So this is nonspecific and is of unknown origin. So this is considered to be idiopathic. "I fell asleep in the back of my brother's car and now my shoulder is killing me." Shoulder is killing him. This you would consider to be a musculoskeletal injury or pain, and so this would be a somatic pain. "I have a stabbing, shooting pain that runs down my leg." There's your stabbing, it's running down the leg, it's probably from a nerve, so this would be neuropathic. So pain is can be managed by analgesics. Analgesics are pain medications, and they can be further classified to opiate agonists. This is for your severe acute pain. This is medications such as morphine, oxycodone, etc. Opiate partial agonists for unrelieved or moderate acute pain, also used for opiate withdrawal, and we'll talk more about that. Opiate antagonists are used to reverse the adverse effects of opiate agonists. Remember, your agonists work with, so your opiate agonists are going to work with and help with the pain. The antagonists are going to work against, they're going to block that effect of the agonist. So patients who have gotten too much opiates, overdosed, they can get an opiate antagonist such as Narcan or naloxone to counteract that. Salicylates, that's your aspirin. This can be used for the more mild to acute pain. And then nonsteroidal anti-inflammatories, also known as NSAIDs, are used for mild acute pain, such as your ibuprofen, your naproxen, ketorolac. When an injury occurs, the body has a cascade of events. So when you have an injury, your body responds by dilating the blood vessels. They increase the permeability of the blood vessels, and they release histamine and prostaglandins. So the histamine and prostaglandins are released, the blood vessels have dilated and increased in permeability, and now they can seep into that area of injury and get to work. So the NSAIDs block the release and decrease the inflammation. So when you give somebody ibuprofen or naproxen or a non-steroidal anti-inflammatory, this medication is blocking the release of the histamine and the prostaglandins from entering that area. Other medications used can be antidepressants such as tricyclics or SSRIs, and then your substance P antagonist. So pain assessment is super important. On page 293 in your book, you will see the Wong-Baker faces, and these are important for kids who cannot put a number to their pain. And on page 295, you'll see your scale of 0 to 10. That's a common scale used for older kids and adults. Reason we have patients rate their pain is so that we can get an understanding of where's this pain at, because it's so subjective. It's going to change from patient to patient. You may find a patient who gets a paper cut to rate it as a 10, and a patient who comes in with a fractured hip is a 6. It's very subjective. So you need to get an idea of where that patient is on their scale. So say you medicate them and their pain's a 10 on 10, and you go back to reassess them, and now they're a 5 on 10, you know that you have made progress with them. So 10 is the most intense, 0 is no pain. And you can also use other tools for the nonverbal patients. Look at them. Are they grimacing? Are the infants crying? Are they consolable? Stuff like that. So pain assessment, the patient's perception of pain. This is what they're experiencing. This is what they're, they believe in this. So you have to respect that. You want to note the onset, the location, the depth, quality, duration, and severity. So there is PQRST you can use to kind of remember that. So P is for pain and perception. Q is for quality. So what does it feel like? Can you describe your pain? R is for radiant. Does it radiate anywhere? S is for sight. Where is the pain? And T is for time. How long has this been going on? When did this start? Non-pharmacological strategies, as nurses, we always start with our non-pharmacological interventions first. Things that we can do before we give them medications or in addition to giving them medications, because this is going to also increase their comfort. So repositioning in bed. If they have an injury, you can apply heat or cold depending on the circumstances. Relaxation techniques. Diversional activities, this is where you can have something that's kind of a little bit distracting to them so they're not focusing on their pain. Decreasing environmental stimuli. A nice, calm, quiet environment is usually helpful. Visualization techniques, biofeedback, meditation, transcutaneous electrical nerve stimuli. That's not something we necessarily see a lot of. And medication. So you want to encourage your patient to request the pain medication before the pain escalates. It's easier to keep a patient's pain under control if you medicate them prior to the pain getting to an intolerable level for that patient, intolerable level. You need to make sure you know when the last dose of pain medication was given so you don't over-medicate them, and use the pain scale so that you have an idea of where you're at. Keep in mind that the age of the patient makes a difference. Kids have a tendency to metabolize medications more quickly than older adults, and geriatric patients metabolize more slowly, so the medication is going to stay in their system longer. PCA, or patient-controlled analgesia. So you'll see and hear this term. This is where the patient is able to self-administer small doses of analgesics. So they have a pump of some sort. It says usually morphine. It can be other medications, dilaudid medications like that. That is either IV or subcutaneous, where they can hit a button and give themselves a dose of the medication. Excuse me. As a nurse, you need to monitor this and record the amount that they're administering, and is this giving them pain relief? The pumps are set so they cannot over-medicate themselves. So if they try to get a dose too soon, the pump blocks that from happening. The nurse is educating a postoperative patient about the use of a patient-controlled analgesia pump. Which statement by the patient indicates a need for further teaching? A. I'm afraid I'll give myself too much medicine and become addicted to it. B. I can only receive the medication every 10 minutes. C. I'll let the nurse know if my pain doesn't improve. Or D. I'll be sure to push the button to give myself pain medication before I get up into a chair. So the question is asking which statement by the patient indicates a need for further teaching. I'm afraid I'll give myself too much medicine and become addicted to it. So the amount of medication that is being prescribed to the patient is not going to be, this is short term, unless it's a hospice patient. When they have a PCA, it is usually post-op and is not a long enough duration for the patient to become addicted. B. I can only receive the medication every 10 minutes. Yes, this is true. The pump blocks them out if they try to receive a dose less than 10 minutes. So that is correct. C. I'll let the nurse know if my pain doesn't improve. Yes, we want the patient to do that. And D. I'll be sure to push the button to give myself pain medication before I get up into a chair. Yes, we want the patient to do this. We want them to pre-medicate so that the pain does not get out of control. So the correct answer is A. PCA delivery is a safe, effective means of pain management that gives control to the patient who is experiencing pain. So now we're going to talk about the drug classes, the opiate agonists. We mentioned that earlier. So remember, agonists work with opiate. So the opiate agonists work with the opiate receptors to help relieve pain. So they act on the same sites in the brain as morphine to stimulate an analgesic effect. They block the pain sensation. The term opiate came from drugs once derived from the opium, which is such as heroin and morphine. Opiate agonists are naturally occurring and synthetic, and they relieve pain. So we do have some naturally occurring opiate agonists in our brain. So we're increased negative synthetic opiates. They act primarily on the CNS, and they can cause sedation, some euphoria, mental clouding, and if they are given for a prolonged length of time, they can cause drug addiction and tolerance. This is generally after use after 3 to 6 weeks. So opiate agonists include morphine, morphine-like derivatives such as codeine, hydrocodone, oxycodone, Demerol-like derivatives, methadone-like derivatives, and other opiate agonists. Common side effects are lightheadedness. They can get sedated. They may get a little sweaty, a little bit disoriented, especially the older adult. They can cause orthostatic hypertension. Some of these medications can cause nausea and vomiting, and all the opiates cause constipation. So it's important to teach your patients, if they're taking opiates, that they need to increase their fluids, their fiber, to avoid that. Serious adverse effects, you guys need to know this, is respiratory depression. So if they take too much, they can completely depress their respiratory system and actually stop breathing. So that is super important, so highlight that. On page 300 and 301, there is a table, 19.1, with a list of your opiate agonists. So it's important to know, your morphines, your hydrocodone, hydromorphone, which is dilaudid, oxycodone, OxyContin. So what's the difference between OxyContin and oxycodone? One is, oxycodone is used for more immediate relief. OxyContin is an extended release, and it's given every 12 hours. So monitoring parameters for these medications, again, you want to assess your pain of the patient. Remember your PQRST, so you want to do that prior to giving the medication. Administer the smallest dose that allows for pain relief. So the smallest effective dose is what you want to give them. You do not want to be over-medicating them with opiates. Remember the respiratory depression component of it. Therapeutic goals just talks about, what is a tolerable pain level for the patient. Here they use 3 on a pain scale. I usually ask my patient once I medicate them and they say they've gone from a 9 or 10 to a 5 or 6. Well, is this tolerable for you? We may not be able to relieve all of your pain, but are you at a level where you can tolerate it? But as a general rule, we'd like to keep them on a 3 or less pain scale, 5 with movement, because we know this is going to increase their pain. And then, very important to hold medication for respirations go below 12 per minute for an adult. You do not want to give morphine or any other opiate agonist if a patient has respirations that are below 12. Which common adverse effect may be seen with the use of opiate agonists? A, appetite stimulation, B, orthostatic hypotension, C, mood elevation, or D, increased respirations. Answer is B. Blood pressure is likely to be affected with the use of an opiate agonist. Opiate partial agonists, these are your Suboxone, Subutex. This class of drugs depends on whether the patient has previously been on an opiate agonist and has developed physical dependence. When used without prior administration, the opiate agonist will have an effective analgesic effect. If given with physical dependence on an opiate agonist, the partial agonist will cause withdrawal. This also has a ceiling effect. So they use this for patients who are withdrawing from opiates, heroin withdrawals, morphine withdrawals, because it has the ceiling effect. It does not give the patient, it doesn't give them the euphoric, by taking more of this, it does not give them more of a euphoric effect. So it helps to fill the brain's opioid receptors without producing that same high. It makes it more difficult for the patient who abuses the opiates because it's also given with naloxone, so it's also giving that antagonist effect. So it has the partial opioid agonist effect, and then when it's the Suboxone, it's a combination of the buprenorphine and the naloxone, and it makes it really difficult to abuse. So it's pretty effective. Here's a list of the medications that are in the drug class for opiate partial agonists. The important one there is highlighted in red. It's the buprenorphine, also known as the Subutex. And serious side effect can be respiratory depression. So opiate antagonists, naloxone or Narcan. This is the reverse respiratory depression. So this is used to reverse patients who have overdosed on opiate agonists. So if you have a patient who now has respirations of 6 and they're agonal because they had too much morphine, you can give them Narcan, and that will completely reverse the effects of the opiate. After receiving a dose of morphine for postoperative pain, a patient becomes unresponsive with a respiratory rate of 10 per minute with shallow breathing. The nurse should anticipate administering which medication? A, naloxone, B, nalbuphine, C, mepridine, or D, pentazocine. A, naloxone. This is your opiate antagonist, so it's going to work against. So patients being discharged with analgesics, you want to make sure that you educate them on the adverse effects that can occur. Again, those are going to be depending on the analgesics. But it's important that they're aware of them and what to do if they occur, when to contact the physician, and also to encourage them to contact their physician if they're experiencing poor pain control at home, and to use the smallest dose possible. So salicylates, this is your aspirin. This inhibits prostaglandin synthesis. So remember when we talked about in the beginning of this chapter that prostaglandins, when there's an injury, prostaglandins are released. You have the vasodilation, you have the increased permeability, and they go to the site of the injury and they increase inflammation. So the salicylates inhibit the prostaglandin synthesis. So we're blocking that prostaglandin from causing that inflammation. So uses: pain, inflammation, fever, headaches, muscle aches, rheumatoid arthritis. Talks about reducing the risk of MI and TIAs and stroke, and this is very true. We are going to talk about that in January. Which classification does not describe a property of salicylates? A, analgesic, B, antipyretic, C, antiplatelet, D, sedative, or E, anti-inflammatory? So the question is, which classification does not describe it? So analgesic, we know it gives pain relief. Antipyretic, we know that it decreases fevers. C, antiplatelet, it helps with reducing the risk for MIs and strokes, so yes. And D, sedative, no, it does not cause any sedating effects. E, anti-inflammatory, yes, it decreases that prostaglandin. So the answer is D. Again, salicylates, the one that you need to know here is aspirin. You may see it written as ASA. Common adverse effects you want to know is GI irritation. Serious adverse effects you want to know, it can cause GI bleeding. So any patient that's at risk for any GI bleeding, they have ulcers or a history of GI bleed, you want to think twice before giving them aspirin. So, or if you have a patient that develops blood in their stool while they're taking that, or vomiting blood, anything like that, you want to be aware. And again, we talked about this last class, but you don't use aspirin in children, and this is because of their risk for Reye syndrome. And again, this is a syndrome that can develop after viral infection for kiddos, and it seems to be that they're more at risk if they received aspirin during that illness. They can also develop aspirin toxicity if they take too much. There's nothing that can reverse this, so you need to educate the patient on not taking too much aspirin. And in the miscellaneous category, you have acetaminophen, which is Tylenol. You should know the generic and the brand name for Tylenol. So acetaminophen is your generic, Tylenol is your brand. This is not an anti-inflammatory, it is not an opiate, so it's categorized in the miscellaneous. We use this for fevers, for pain reduction. Serious adverse effects is for can be toxic to the liver. So if a patient takes too much, you will worry about their liver. It works by inhibiting the prostaglandins. It also works by blocking the pain impulse from the CNS to the peripheral tissues, and it also lowers the temperature by inhibiting heat regulation in the hypothalamus. So it works in the hypothalamus as well to reduce fevers. So signs and symptoms of toxicity: anorexia, nausea, vomiting, low blood pressure, confusion, abdominal pain. Later signs would be jaundice, remember liver, increased AST and ALT, those are liver enzymes. So we look for those. So this slide says 4 grams, but it actually should be 3 grams of Tylenol daily. They recently changed that as of last year. So the maximum dose used to be 4 grams, but it is now 3 grams. So just remember 3 grams in 24 hours for your adult is the maximum. There is an antidote, acetylcysteine, that can be given if there is an overdose. Also, keep in mind that there are medications that are combination medications that are in a chart in your book as well, that have a combination of an opiate and acetaminophen. So, example is Percocet has a combination of oxycodone and acetaminophen. So you want to always make sure you educate your patients and tell them that there is Tylenol in Percocet, so you don't want to take Tylenol in addition to your Percocet. Another example would be Vicodin or Norco. So just be aware of that. And here you go. Here's the combination medications. This is on page 313 in your book. And NSAIDs, non-steroidal anti-inflammatories. These are aspirin-like, but they're not related to salicylates. So these are prostaglandin inhibitors. You also have your COX-1 and COX-2 inhibitors. They are used to decrease the inflammation, hence their name. So pain reliever and inflammation reducer. Examples are on page 311 in your book on table 19.3. Some of them are listed here. The big ones to know are ibuprofen, and it's very, very important to know that Motrin, so ibuprofen is the generic, and then you have your brand, so Motrin and Advil. Some patients don't realize that ibuprofen and Motrin are the same medication, or ibuprofen and Advil are the same medication. Those are the same medications. It's just one's a generic and one's a brand. Diclofenac, that's also known as Voltaren. That should be lowercase because that is your generic, the diclofenac. Voltaren is the brand. Common adverse effects: gastric irritation, constipation, dizziness, but just remember gastric irritation with NSAIDs. You want them to take this with food so it doesn't upset their stomach or irritate it, cause a gastritis. It can cause GI bleeding. So again, anybody who is at risk for bleeding, you want to think twice. What is a common but serious adverse effect of non-steroidal anti-inflammatories? A, increased upper GI bleeding, B, excessive drowsiness, C, antipyretic action, or D, diarrhea. So common but serious. The answer is A. 7 to 8% of patients experience GI bleeding after using an NSAID. And that is the end of chapter 19. If you have any questions, feel free to shoot me an email.